Please, Jean, this is, I know that it's informal, but this is a question that I want to do in front of everybody. Explain to me your CV very quickly.
Well, I'm Jean Bourhis, I'm a radiation oncologist in Lausanne University Hospital in Switzerland. And I used to be the chairman of radiation oncology in Institute Gustave Roussy.
For how long?
For 10 years.
10 years.
And which is long enough. And I moved to Lausanne afterwards, and I became also the head of radiation oncology department there for 12 years.
12 years in Lausanne.
Yes. And I also, during all these times, I was running both the clinical side and the laboratory side in parallel with laboratory for translational research in radiation therapy.
Yeah. I know that you have always working with head and neck tumors and interlap, like you explained to me. But I know you are the father of flash therapy. Explain to me when this idea comes to you. Or it comes for a lot of years, or it was just one day. Sometimes they explain that the scientist has an idea, a very bright idea one moment, and they begin to work in that or not. It's a progressive idea that you have.
Absolutely not. It's just serendipity.
It's a what?
Serendipity.
Really?
Well, if you want to know the real story of this flash therapy,
of course I will.
Everything started in Curie Institute.
Yes.
Where Vincent Favaudon, who was a scientist there, he was asked to irradiate mice for doing lung fibrosis, so for side effects. And he irradiated the mice with dose for fibrosis, but he irradiated one with flash. And a long time after, the veterinarian school called him and thanked him and said, well, thank you very much, you did a very good job for doing fibrosis in the lung, but you forgot to irradiate one batch of mice.
And you have irradiated this?
No, he was aware he had irradiated them with flash and there was no side effects. So he immediately realized that something was happening there, and he was starting working with us in Gustave Roussy Institute. And
this was when?
Well, it was 2009 or so.
Okay.
For maybe 2 years, he and our scientist, Marie-Catherine Vosnin, they came to me and said, well, we don't see side effects when we irradiate this way. And I told them, well, just check the dose, because your dose is not right. And after 2 years, they put a tumor in front of the beam, and the tumor disappeared. And from this moment, I really realized something was going on, because you have less side effects, the tumor disappears. So we move forward very fast from that point to where we are now, because
then the initial idea came from something, not
from
something
nowhere. No.
from an answer.
You know what we discovered afterwards is that this phenomenon was already described in the 60s and 70s. At least there are 10 or 12 publications on that flash is sparing the normal tissue, this dose rate, but they never looked at the tumor at that time. So they thought it was useless because it was sparing.
Very interesting, the things that you have explained to me, because it's surprising how the new things in medical oncology, radiation oncology, in so many things is something.
And you know, initially they missed it because they just didn't look at the tumors.
Really?
Yeah, they looked at normal tissue only, and they said, well, it's sparing at this dose rate. We are sparing the normal tissue, so there is no need to use that in tumors. And it was 30 years without looking at this.
But you know, it's so interesting that now flash therapy is something that my question is, do you think that flash therapy will be the future in the field of radiation oncology?
Well, flash therapy is maybe an additional tool to try to increase the effect, the differential effect between tumors and normal tissues. It's certainly not the magic bullet. We will try to understand how we can have this on top of high conformity that we need for irradiating our patients, and on top of fractionation, if we can use that.
Then do you think that flash will be something to be added to the normal treatments?
It has to be added because it cannot replace what we are doing.
Okay,
so that's the way we should develop that.
I think this concept has to be explained to our young people, to our young radiation oncologists, to the young biologists, etc. But because I think it's not the future.
No, it could be integrated in what we do, but it will replace nothing.
and in another topic, you are very involved in a lot of trials.
Yeah.
You are, I think, the president of the GORTEC now. That is one of the main groups of people doing clinical trials. That's right?
Well, GORTEC is a cooperative group working on head and neck cancers.
I know.
And we created that 30 years ago.
And my question is, flash therapy will be a complementary treatment to be added to our normal treatments.
Yeah.
But the drugs also, like in the GORTEC trials,
Yes.
Drugs will be also complementary to the treatments that we are doing. Do you
Right.
think drugs, the new drugs, the old drugs, cisplatinum, all the drugs that we are using now will be also the future, like a complementary treatment in radiation oncology?
Well, it's a difficult question. What we know is that when we combine the old drugs like cisplatin with radiotherapy, it's just better than radiotherapy alone, if we can do it.
Cervix, in head and neck.
Yes, we have so many examples. Now we have so many drugs that are candidate maybe to improve what we do with radiation therapy. There are so many, I think it's overwhelming. But we need to test and see whether one of them will work. And it's not easy because we have very, very few examples at the moment of new drugs, new molecular targeted agents or immunotherapy that is really working with radiotherapy. It's very little at the moment, but we should keep fighting on that.
And you are testing a lot of new drugs with your clinical trials?
Yes, absolutely.
And one question that I have that I think is important, very often, in France it's probably not the case, but very often in Spain, radiation therapy has to be prescribed and done by the radiation oncologist, but drugs has to be prescribed and controlled by the medical oncologist.
Yes.
And I think this is not right. This is my opinion. I think that depending of the drugs, it can be used by radiation oncology, it can be used by medical oncology. Yeah. What's your opinion about that?
Well, it's, if we look at the figure in Europe, it's really completely different.
Yeah.
In the north of Europe, they used to have clinical oncologists who are both radiation oncologists and medical oncologists, and they prescribe. But in France, I think it's possible to prescribe drugs when you are a radiation oncologist, but it's not common practice. More and more we have specialists in medical oncology for doing it. In Switzerland, where I work, it's also separated.
Medical oncology one side, radiation oncology the other.
Yeah. You can prescribe it, but it's not really the common situation.
More questions, my reflections that I have to make to you. Technology. Technology, I think technology has been very important. Biology also, because you explained to us, biology, flash therapy is biology. But technology is also very important in our field of radiation oncology. And then my question would be, we have a new technologies development nowadays in radiation oncology, and one of them is the adaptive radiotherapy. This is a type of treatment that is very time-consuming for physicians and for physicists. Do you think that adaptive radiotherapy will be also the future for us? Or do you think we have? I need your opinion. I would like to know.
You know
opinion.
what happened in radiotherapy throughout the last decades is that we were more and more precise.
Yeah,
I mean, high precision was coming progressively with IMRT, with stereotactic radiotherapy. Even proton therapy is something really precise. So at some point, we are in a sort of plateau. We cannot be more precise than precise. And if we are more precise, at some point, we may miss the target. So we have to be careful to keep the margins, to keep everything safe. And from there, how are we going to improve things? I think it could improve still with molecular imaging, because we could be able, to pick some very small tumors somewhere. We know from the PSMA story that we can, when your PSA is raising, you can really identify a small node or small metastasis you can kill afterwards with radiation. So that's a way also to be more precise. Now adaptive radiotherapy is, it's not going to be a revolution in our field. It's a little bit of adjustment of being a little more precise and then reduce perhaps a little bit, but very little, the margins.
But you know, I agree completely with you, because we have a precision in radiation oncology that diagnostic do not have. When you do a CT scan, when you do an MRI, when you do a PET CT scan, you have a precision that is not a completely true precision. You don't have 1 millimeter precision. You don't know exactly if this has 1 more millimeter or less millimeter.
Yeah, but they don't mind.
But the point is, if we are so precise in radiation oncology, we can skip out of the field a part of the tumor of the microscopic disease, and I agree completely with you. I think we have more to develop imaging to know exactly where the tumor is.
Where is the tumor? Yeah,
you think that is the...
Yeah.
And what about artificial intelligence?
Well,
this is a thing that is everybody speaks about artificial intelligence.
Yes.
What do you think about that?
Well, I'm really convinced it's going to improve our daily life because it's a tool again. I mean, it's not going to make a big revolution in the care of the patients, but our daily life for sure, because we have some tasks in radiation therapy which are really repetitive. When you want to do a contouring for breast cancer, for instance, my goodness, it's really...
this can be done by a machine.
Yeah,
and then
it's a lot of time. And same for dosimetry. For simple cases like this, if you have a auto dosimetry, which is automatic, then you spare a lot of time. So I really believe that it will be helpful, and it can be also bringing a lot of quality to what we are doing, because if you feed your model, your artificial intelligence model with good data you have checked, you have double checked, and you enter this in the system, then what you get back is quality. So I think we can gain on quality, maybe security of the treatment, and efficiency. So it's something that will develop anyway. It will be developed. I don't think we can stop this.
And more questions. Everybody speak about protons, hypothermia, etc. Probably protons, a lot of people speaks about protons. That will be a reality in France. It will be also a reality in Spain. But what about hyperthermia? I don't know in France, but in Spain, hyperthermia is more and more important. What do you think about, for instance, hyperthermia?
Well, hyperthermia is a fantastic radiosensitizer and chemosensitizer. It's a pity it has not been used extensively. And it's hard to know and to understand why, but certainly we should try to keep developing this. I think new tools also are around, maybe more practical for use, and I think it's still a great opportunity for radiation therapy.
And hyperthermia can be like flash therapy.
Yeah.
A complementary tool to improve the results that we obtain nowadays.
And it's a pity that it took so long for developing this. I don't know why the uptake has been so slow.
But you're right. It takes for hyperthermia to have that for 40 years. But really, phase 3 trials and new trials with hyperthermia are not done very often. I completely agree.
But we have evidence that it's working with chemo and radiotherapy.
And with chemo also.
Yeah, in sarcoma.
In sarcomas and in some local relapses in breast cancer, it seems that, and gynecology also seems to be effective. Okay. Very interesting. Another question. Head and neck tumors. You are an expert in head and neck tumors. What is the future for head and neck tumors? Locally advanced. I'm not speaking about the small tumors, the T1, the T2, that the majority are cured. I'm speaking about T4, T3 tumors.
Well, locally advanced cases, what we have to do is try to avoid sort of mutilating surgery when we can preserve organ or functions. I mean, it's really important for the patient. But sometimes surgery is still better because it's more efficient in removing the tumor and curing the patient. And for those patients we don't operate, I think it's just amazing to see that we are still using cisplatin and radiotherapy as standard of care. It's 3 or 4 decades now since we've done it. And every time we try to challenge this by adding immunotherapy, adding whatsoever, never worked. So the only thing which was proved to work was EGFR targeting, but it's not working as good as chemotherapy. It's certainly not as efficient. So I think we have a really unmet clinical need for having more efficient and better tolerated treatment, because it's hard for the patients also, this radiotherapy plus chemo.
But the question is, and the new treatments are so expensive with the new drugs added to the therapy. Do you think we can pay that? The public health can pay these prices of new drugs?
Well, I don't know. It's
immunotherapy, for instance. Immunotherapy.
It's hard to say, but if you cure more patients and you cure without side effects, let's say, the cost effectiveness of this early treatment can be relatively favorable, because a head and neck cancer patient who does relapse, it's a lot of cost also, because he has to go to the hospital and a lot of complications and so on. So it could be very costly also not to cure the patients, in fact, especially for head and neck cancers, because it's quite devastating, what's happening there. So.
I have one last question to you. Between you and me, future of radiation oncology. What's the future of radiation oncology in general, not particularly for one thing?
I think what is really important to see is that the whole oncology is moving forward quite fast in developing new drugs, more and more efficient. We saw that, for instance, the crizotinib targeting ALK, the initial one was working. But those they have now, crizotinib-like, they are better, more efficient, better tolerated. So this is not going to stop. We will see this movement for the next decades, and at some point it will be more efficient in curing patients safely. So what radiotherapy is going to do with this? I think one very important part of the development in radiotherapy is ablative stereotactic radiotherapy, because it's so complementary to all these new developments in oncology that we need really to make sure that we move.
Short treatments, very precise, can be combined.
You can repeat it, you can, very, very little side effects, highly efficient. It's best, or the reference, I would say, ablative treatment that we have at the moment.
And protons has a place in that?
Well, protons is more complex, because proton, it's on the tumor itself is not going to make a difference. The proton are probably delivering less intermediate dose you know, not the high dose. The high dose around the tumor will be around the same as what we do with conventional, but you have less intermediate dose. So it's hard to find a benefit, a clinical benefit for that, but at least it's probably better to have less dose in a patient for the same result. So proton therapy is okay, but it's not maybe the revolution we expect. And you know, it has been around for 40 years now,
and there is not so many clinical
the uptake is really slow. I mean, in Europe, I say we have probably 0.3 or maybe 0.4% of our radiotherapy patients treated with proton. So there is a long way. Even if we have 10%, it would be a very long way.
But the thing that I have today in the session that we have with the Catedra Universidad de Barcelona Atrys, what I have said is that we have to work together. Radiation oncologists,
Absolutely.
medical oncologists, biologists, engineers.
Yeah.
That is probably the future.
Radiologists.
And of course, I forget radiologists, and radiologists, and nuclear specialists, nuclear medicine specialists.
Absolutely, yeah.
Okay.
Thank
My
you.
friend,
Thank you very much.
That's always a pleasure to see you. See?